Thank you. The topic of my talk is potential challenges to doctor-patient trust posed by personalized medicine, and I will be very old school and simply read without a PowerPoint presentation. It's just that describing the phenomenology of trust between people doesn't lend itself very well to a PowerPoint presentation. But I will raise my eyes from time to time to check that you're awake. Okay. Personalized medicine, or the prevention, diagnosis, and treatment of patients according to precise information about a person's genes, proteins, and environment, is widely recognized as an important vision for medicine. Yet, despite the impressive increase in the number of clinically useful molecular diagnostics and targeted therapies, the routine incorporation of personalized medicine into clinical practice is still mostly a future promise. Indeed, personalized medicine is usually not even discussed at the point of care. The still very modest incorporation of personalized medicine into the clinic is mirrored in ethical reflection on personalized medicine, which has thus far given little attention to the clinical ethics aspects of doctor-patient interaction under personalized medicine. This paper will look into a crucial parameter of the doctor-patient interaction that has not yet received consideration in the bioethical literature, the possible negative effects of personalized medicine on patients' trust in doctors. The paper begins with a short discussion of trust and its relevance, and then proceeds to analyze potential caveats regarding the effects of introducing personalized medicine into the clinic on patients' trust in their doctors. So the first section is about trust and specifically doctor-patient relationship. Trust is an attitude that we have towards people who we hope will be trustworthy. It is our faith in others that they can be relied upon, that they will not betray our expectations. Trust is fundamental. It is of fundamental importance to human relationships and to social functioning generally. Were trust to be absent, people would not be able to interact with others even at a superficial level or carry out cooperative activities. Societies would disintegrate into a Hobbesian state of nature, and the things that matter to human beings could not flourish. In contrast, basic trust encourages us to see and respect each other as moral agents. In a climate of trust, intimate and professional relationships can take shape. Trust allows us to form relationships with people and to depend on them for love, for advice, or for help. Trust thus redeems us from the poverty of exclusive self-reliance as well as from existential solitude. On a more specific level, trust is of great importance to the doctor-patient relationship. Sick people have always had a particular need for trust because to fall ill implies a loss of trust in yourself, in your body, in your social role, in your future. This loss of trust fortifies the need to trust others, among them the doctor. Both due to their vulnerability secondary to their illness and to the asymmetrical knowledge of medicine, patients tend to trust doctors, transferring to them the power to act in the patient's best interest. Numerous studies have shown that patient trust has an impact on patient satisfaction, adherence, continued enrollment, and other parameters. Thus, acting in ways that justify and perpetuate patient trust is not only ethically right, but also of great importance for the quality and success of healthcare. Trust has two main forms, interpersonal trust and social trust. In the first, people place their trust in other individuals, such as in their physician. In the second, the objects of trust are collective institutions, such as a healthcare system. Social trust in the healthcare system and interpersonal trust in physicians diverge in important ways, but they are also mutually supportive. Patients who trust their physicians will generally tend to worry less about the trustworthiness of the system, and similarly, trust in one's physicians can flow from confidence in the competence and commitment of the institutions with which they are affiliated. The latter direction of influence, that is the influence of trust or mistrust in elements of the system on trust in its doctors, is pertinent to our project of assessing possible influences of personalized medicine as the modus operandi of a healthcare system on trust between patient and doctor. To wit, while trust grounded in the doctor's personality, e.g., his caring attitude, honesty, or high sense of responsibility for patients, should remain constant whatever the system's profile, system characteristics, in particular in our case, the system's adoption of personalized medicine, can influence the doctor's perceived and even actual trustworthiness, as I discussed below. It may sound prima facie odd that there should at all be any challenge to doctor-patient trust associated with personalized medicine, given that it is an advancement of medicine for the benefit of each individual patient. In this regard, two clarifications are in order. First, to the extent that personalized medicine is continuous with current medicine, e.g., if it does not proceed beyond a more precise subclassification of diseases based on genetic markers, then the caveats below will indeed be mostly irrelevant. Conversely, the more personalized medicine turns out to be a grand-scale big data revolution, as in the title of this conference, the more it turns out to be a paradigm shift that ushers a fundamental change in the way medicine is practiced and delivered, the more serious the following challenges may become. The second clarification is that my intention is emphatically not to claim that the concerns discussed below are devastating or insurmountable or unmitigated by significant offsetting benefit, or even that they are, to at least some degree, necessary. The idea is rather that they are potential challenges of which we should be aware so we can address them if necessary in order to benefit optimally from the advantages offered by personalized medicine. Researchers broadly agree that patients' trust in physicians consists mostly of the following dimensions: loyalty or caring, competency, honesty, and confidentiality. My discussion of personalized medicine will refer to all these domains. So I start with trust in the doctor's wisdom. Competence is among the most important factors responsible for trust in doctors. At times, it is identified as the most important. Although competence includes a number of capabilities, the most important arguably is the doctor's clinical judgment. Accordingly, Skirbeck and colleagues interpret trust as the patient's implicit willingness to accept the physician's judgment in matters of concern to the patient. Good clinical judgment, in turn, comprises various parameters. Two central ones that elicit trust are the doctor's relevant knowledge, and even more importantly, the doctor's wisdom. Now, there is reason to suspect that personalized medicine may exert negative influence on the dynamics of trust as far as these parameters are concerned. In classical medicine, the doctor had knowledge of the natural course of the disease, which he could share with the patient. The more personalized medicine indeed becomes personal, however, the less will there be natural histories to people's diseases about which the doctor could counsel the patient. The reassuring effect of having a clear narrative to one's woes, which allows reasonable expectations, and the trust in the doctor who provides such a narrative could diminish. More importantly, in classical medicine, doctors accumulate clinical experience and insight in treating patients suffering from specific diseases, which they can later share with new patients with the same disease. Clinical wisdom, based on years of practical experience, is an important capability through which doctors help patients think of best strategies for coping with their illness and of how to optimize well-being despite debility. Beyond the citation of pieces of medical information, clinical wisdom expresses the art facet of medicine. What will happen to it if or when personalized medicine indeed accomplishes its revolutionary potential? The more personalized medicine indeed becomes strongly personal, the more difficult it may become to apply such kind of wisdom in clinical practice. Medical recommendation will veer much more toward being a machine-generated computational output. Such output will be the culmination of collecting genomic, transcriptomic, proteomic, epigenomic, metabolomic, and nutriomic data, as well as patient-related data on environmental, behavioral, and socioeconomic factors. This data mountain will then be subjected to the mercy of bioinformatics, biomathematics, and biostatistics for data integration, analysis, and interpretation, and then to further algorithms to suggest optimal treatment. The doctor will understand precious little about the considerations that generated the computed medical recommendation. Indeed, often there will be nothing to understand, as the output will be the outcome of the brute force of mathematical and statistical computation alongside an elusive and incredibly complex patchwork integration of bioinformatics decisions regarding the choice of multiple algorithms that generate the correlations. It will presumably also incorporate massive data generated blindly via machine-to-machine communication through the Internet of Things. If this revolutionary scenario or something resembling it comes to pass, the doctor, to put things a bit starkly, might be reduced to a sophisticated clerk who communicates machine-generated bottom-line conclusions to the patient. No one knows precisely how the clinical encounter will look like under such circumstances, but there's reason to think that at least some aspects of clinical wisdom might be lost, and with it, the more traditional sense of trust in the insight and good advice of a wise doctor. To put things in perspective, some are concerned even today that doctors rely too heavily on medical decision-making algorithms, and that this has adverse effects on clinical judgment. In his book, How Doctors Think, Dr. Jerome Groopman, chair of medicine at Harvard Medical School, asserts definitively that, quote, algorithms discourage physicians from thinking independently and creatively, end of quote. In the revolutionary personalized medicine scenario, the shrinking of thinking problem can increase to qualitatively new levels. The doctor will not employ algorithms anymore. He will more likely be employed by them, having to base much of his advice on parroting their conclusions. To an extent, the doctor will become a Google searcher in a world of big data medical informatics. It is worth mentioning that Groopman's insight is true more generally than in medicine. Wisdom and following algorithms are two very different things. In fact, there is a sense in which they are mutually exclusive. Whenever we can follow an algorithm, wisdom becomes superfluous. It is when there is no algorithm for how to think or act that wisdom reveals its indispensability. Indeed, we often need wisdom in order to choose the right algorithm for the situation at hand. But this is precisely because there is no meta-algorithm that governs the choice of the right algorithm for each situation. To the extent that trust is a response to wisdom, we should be vigilant lest a personalized medicine revolution diminishes trust in doctors. The next section is trust and the rapport between doctor and patient. It is a truism that interpersonal trust thrives in conditions of intimacy and good communication. We are interested to examine the concern that a personalized medicine revolution might enhance some problematic trends in this regard. While it would be silly to dispute the tremendous benefits that computer technology had brought into medical practice, a downside which has received some attention involves the effect of the introduction of electronic health records into the clinic on the communication pattern between doctor and patient. After a short greeting, doctors tend to spend the first minute or few minutes of the consultation interacting with the computer rather than interacting with the patient or discussing the patient's agenda. Often, it is the information on the screen that prompts the doctor's opening statement instead of inviting patients to share their concerns and being responsive to them. Rapport is often undermined even when physicians do finally attend to the patients themselves, as physicians type in data or gaze at the screen when talking to the patients or when the patients talk to them. According to one study, physicians spend an average of 24 to 55% of the visit time gazing at the screen. This consultation time is inevitably short, since consultation time is inevitably short and mostly fixed, and since physicians, like everyone else, have trouble multitasking in the sense of interacting simultaneously with a computer screen and in a meaningful way with the patient, time interacting with the computer is inversely related to physicians' focus on the patients themselves. The result is that screen-driven communication inhibits patients' narratives and diminishes clinicians' responses to the patient's cues about psychosocial issues and emotional concerns. The rapport between doctor and patient is damaged. This state of affairs is anything but a marginal side effect of the electronic health record era. Patient-doctor communication is a crucial component of the healthcare visit, shown to have ramifications for patient satisfaction, adherence to treatment, conflict resolution, laboratory costs, and clinical outcomes. Now, where face-to-face communication falters, the ability to forge relations of trust is hampered. And in revolutionary personalized medicine, with its fundamental reliance on consulting big data edited via sophisticated bioinformatics, doctors' need for computer interaction in order to manage patients is likely to increase significantly. This in turn is likely to present additional strain to good doctor-patient communication, and in turn to the sort of dynamics that forge trust. The challenge to attentive, face-to-face doctor-patient interaction is but one aspect of the challenge of developing trust in the computer-age clinical encounter, and not the deeper one at that. A deeper issue is the very nature of a medical consultation in personalized medicine, where technology becomes a central presence in the room. Although in many, it may sound curious, even in today's clinical practice, computers have been perceived as third parties in the exam room, which compete with the patient for the clinician's attention. The essential point is that trust flourishes in conditions of intimacy. And in this respect, the relevant question is which elements that enter into the secure realm of the clinical encounter are experienced as external agents that encroach on or intrude into doctor-patient intimacy. In his James Mackenzie lecture delivered at the Royal College of General Practitioners, Professor Per Frugelli wrote, "Modern times are characterized by the intrusion of external parties into the doctor-patient relationship. The autonomy of the GP and hence the capacity to create trust is now compromised by big business, big government, big science, and big brother." End of quote. It is perhaps easiest to understand what is meant here by big business being an external party or third party or an external agent in the doctor's office. A prominent example which has been investigated in that respect and documented are the challenges posed by managed care to doctor-patient trust. Now, the idea of science, too, can be, the idea that science, as per the quote that I brought in just now, the idea that science, too, can be an external agent that disturbs the intimacy of the clinical encounter may sound not only strange, but outright infuriating. And indeed, I believe that technology would be the more appropriate term here. Frugelli supports this with an intuitive insight. He writes of the examination room. "In the room of trust, the patient will feel secure with low technology and high fidelity. In the room of angst, there will be cravings for multiple tests and sophisticated referrals." End of quote. While this connection between trust and being satisfied with low-tech medical wisdom does sound right with respect to classical medicine, the idea of technology as a third party entering the clinical relationship is easier to understand in personalized medicine, which, in order to be revolutionary, will have to be based on computers doing much of the medical thinking and counseling. Lee Hood, in your position paper, reports developing, I quote, a new type of artificial intelligence algorithm that has the ability to precisely reproduce the thinking of clinical experts for acute and chronic diseases using virtual intelligent Lego blocks which can interact with one another. The result is a deep reasoning system into which one can then feed the symptoms and data of an individual and which produces insights to help inform a physician in regards to diagnosis, therapy choice, and strategies for treatment in the future. End of quote. In this case, it becomes easy to see how technology could be perceived quite tangibly, in fact, as an external agent in the exam room. When this comes to pass, the new technology will surely make wonderful contributions to the provision of healthcare. This being granted, we will be better off if we remain attentive and react constructively also to the potential challenges it may pose to the intimate character of doctor-patient relationship and consequently to trust. Now I move to discussing trust and confidentiality. The intrinsic connection between confidentiality and trust needs no explanation, nor does the special importance of confidentiality in health matters demand elaboration. Indeed, confidentiality has been a cornerstone of medical ethics since at least the Hippocratic Oath. The meaning of confidentiality has been relatively straightforward in traditional medicine, with dispute being confined mostly to the question of the stringency of that duty. That is, whether it is absolute or not, and if not, what should count as justified deviations. The traditional idea of confidentiality in medicine has presupposed the paradigm of a private setting of doctor-patient interaction. However, that implicit assumptions underlying the ethos and ethics of confidentiality is expected to undergo significant change in revolutionary personalized medicine. Personalized medicine involves reliance on the genomic profiles of patients. It is hence to be expected that the future standard of care will include whole genome sequencing as a basic part of every patient's workup. This genomic, as well as other omics profile, will then be added to a central biobank for further analysis and management of the case. In certain respects, this general scheme for patient management bursts the private setting paradigm of doctor-patient interaction. The expansion of basic clinical assessment to include genome-wide association studies implicates the clinical encounter with problems of confidentiality associated with biobanks. As already mentioned, the problem of confidentiality is ipso facto a threat to trust. Let us elaborate a bit. Studies have demonstrated quite significantly public concern over privacy of personal data in biobanks. This concern is not unjustified given the potential significance of the associated privacy interests and the significant challenges in protecting the privacy of such data. Confidentiality concerns are a function of well-known privacy interests, notably the potential for discrimination by employers or insurers, shame due to disclosure of intimate medical information, breakdown of family relationships by unintentionally demonstrating missing or unknown relatedness, anguish over proxy harm to family members who share genetic material, and also an interest in privacy per se, unrelated to any tangible harm beyond the sheer exposure. With respect to the challenge of securing the privacy of personal data in large data sets, I will here but mention the most intractable point, which has received considerable attention, namely that even anonymity cannot reliably prevent re-identification. The problem is compounded by the fact that the more we attempt to make anonymity irreversible by omitting information associated with biospecimens, the more we diminish the quality of the data as substrate for wide association studies. In sum, since new genomic analysis technologies are outpacing currently available protections in large, often public data sets, breaches of confidentiality are a growing concern. In personalized medicine, these issues will presumably be integrated into run-of-the-mill clinical practice that will depend heavily on big data. The problem of confidentiality associated with biobanks will thus transfer to the doctor-patient relationships and affect trust. There is another section that speaks about problems associated with informed consent in the context of biobanks, but I'll skip that because I have another 5 minutes. The next section, the last section, is about trust and commitment to the best interests of the patient. A prominent ground for trusting is that the caregiver accords the highest priority to the patient's interests. That anyone should raise concerns regarding the priority of the patient's interest in personalized medicine may sound confused, given that personalized medicine raison d'etre is to provide tailored medical care to the individual patient. And yet, a potential challenge arises even in this regard. To understand the caveat, we should revisit the mechanism of medical decision-making in revolutionary big data personalized medicine. Revolutionary personalized medicine poses formidable challenges of data generation, management, integration, analysis, and interpretation. After having processed large-scale, robust genomic data, there arises the challenges of interpreting the functional impacts of genomic variation, integrating data to relate complex interactions with phenotypes, and then translating these discoveries into medical practices. Much of the challenge is of bioinformatics, namely the hugely complex undertaking of reliably estimating many parameters and correctly inferring meaningful associations from multiple hypotheses tested simultaneously. Attempting to reduce dimensionality in order to overcome difficulties of interpreting multiple testing involves the costs both of inserting measures of arbitrariness and of loss of information. In short, omics data, let alone more holistic personal data, quote, embody a large mixture of signals and errors where our ability to identify novel associations comes at the cost of tolerating larger error thresholds in the context of big data. End of quote. The upshot of all this is that while personalized medicine will have higher specificity for the patient, it could simultaneously face a problem of diminished accuracy. Furthermore, we should emphasize in this respect that pattern recognition applied to big data by machine learning could arguably not by itself provide a causal explanatory basis for medical recommendations unless overarching scientific theories for the conversion of multidimensional big data into mechanismic knowledge are developed and prove successful. Without the relevant knowledge, medical doctors would be, in this scenario, at the mercy of machine-generated population-based correlations with all their shortcomings. We may assume and hope that professional standards will successfully sift out results whose level of accuracy is insufficient. But the tricky question is, what would count as accurate enough? While there is little doubt that personalized medicine will improve, perhaps very significantly, the healthcare of the average patient, or the average level of health, or put simply, will improve public health, the ironic point is that this may not extend to every specific patient. The medical recommendation will be a function of wide association studies, which we grant will be statistically responsible, but which nonetheless may not represent accurately the case of each specific patient. Again, remember that the causal explanation for the medical recommendation will often not be known. In conventional medicine, too, of course, the individual patient may suffer from treatment that was statistically established as helpful to the population overall, and this is precisely what personalized medicine set out to correct. But in conventional medicine, this dependence on population averages is the best that medicine can offer. In a revolutionary future of personalized medicine, on the other hand, we face the possibility that in certain cases, the new algorithms will be much better for public health, because much better on average, but worse than conventional medicine for some individuals in some cases. This would drive a wedge between personalized medicine's value for public health versus for clinical medicine, in the sense of being the best treatment for each individual patient. Such a prospect can raise the primum non nocere objection in the context of personalized medicine. Protecting against breaches of primum non nocere is basic for medical ethics and could have an adverse effect on trust in the healthcare system as well as in the doctor who is its representative. In conclusion, it is indisputable that patients' trust in the healthcare system is, in general and in doctors in particular, is of great importance for good healthcare. It is similarly a truism that trust is hard to win and easy to lose. Once trust is damaged, suspicion emerges, and relations marred by suspicion can in turn precipitate fast deterioration of trust. This is so both because it is of the inherent nature of mistrust that once its seeds are sown, it tends to grow quickly, and because mistrust tends to be, two more lines. I'll even skip them. Hence, as a general truth, it is important to be vigilant in matters of trust, to anticipate potential challenges, and then if they arise, to address them quickly and decisively. Awareness of the potential challenges discussed in this paper increases the chances of optimizing the tremendous potential benefits of personalized medicine. Thank you.